So thanks everybody. At least now I'm in my second year here, so most of you know me by now. But I'm new to the world of industrial hygiene. My background is in material science, mechanical engineering, and design. And again, when we applied for these, this was like March of 2024. I'd only been here for like 6 months or something and was still learning a lot. So this truly came out of a place of asking dumb questions and I hope leading towards interesting conclusions and results. But I think you'll see what I mean as we go. So this came from what I think of as kind of asking one, ignorant, the dumb question, but I walked in the room and truly didn't know. I'm working with Dr. Jun Wong. He has a lot of headforms all over the place to test these different respirators. And I just looked at them and it was really interesting because the question was just like, why do they all look pretty similar and they all look like me? And I was just kind of curious because I've never been in this sort of respiratory health environment and was wondering why there wasn't a bigger diversity of headforms, different models, et cetera, right? So this is just a couple of examples. The ones on the far left are the really nice, highly engineered respiratory health sort of headforms. We have one that Judith was using in her study, and shout out to Judith for being a good sport, thank you, and for going ahead of me because it led perfectly to what I'll talk about. And there's other ones. Again, this is like down to the styrofoam headform, $10 from Walmart, right? And kind of there's a couple options in between. But then the question was, where do these actually come from? And so I was digging into the very large amount of work and thought that NIOSH has put into this topic of how do you design good respirators? How do we provide headforms and test platforms to researchers and companies to develop things that work for as much of the US population as possible. So these are just tables from one of their key paper on recruiting over 3,000 people to measure their head, right? And they did this, I think, in the olden days, purely physically with measuring key points. They redid this with 3D scanning technology and then created these headforms that are representative of these tables. But again, the point of the tables is just they recruited thousands of people to do this. They took, this one is just different points on the head that they measured. So each person was subjected to like 20 different measurements, right? So they did their best to get a very broad perspective of the US population. But what's really key, the first table up on the top left is kind of the demographics of who they sampled. And the second table is the weighting of that, because what they were trying to do is boil all of these thousands of measurements down to 5 models that they can give to manufacturers, researchers that they said would cover, quote unquote, 95% of the population. So that's what we'll get into, is I think that really is the roadblock, is the concept. So in terms of why do our headforms look the same, it really just boils down to, we have access to headforms that we can buy, or DIY if you want to go buy the one from Walmart and then put all the effort in to make that into a viable respirator testing platform, non-standard at that point, of course. Models strive to meet the NIOSH test standards, so companies are trying to meet best practices. And then the NIOSH test mannequins were based on weighted facial geometry, so that was the core concept. So then anything else outside of that has to be a DIY project, effectively. So then the question is, why should we even try anything different? I think that's where we got into this particular project and the motivation for home healthcare workers. There's really 2 key things. One is, does the fit matter? So this is where I thank Judith, because she was directly testing secondhand smoke exposure. We know that is an ongoing issue for home healthcare workers, and there's many other environments actually where secondhand and third-hand exposures matter. And fit of a respirator is really critical in that. So in her previous testing, she was doing good testing. So again, it's, there wasn't any negative critique on that work. the issue is that if you can have a mask with 99.9 protection, but if it has a poor fit, you still only get 30 to 40% reduction in of the actual protection, right, or the of the pass-through particles. And so fit is really key. So then the question is, how do you figure out how to get towards perfect fit on every person every time? Because that's clearly the barrier. And this is especially important for underserved minority groups, because we go back to this huge set of work and tables. We've taken thousands of people and boiled it down to 5 models. So you're basically averaging out a lot of diversity. So then if that's our goal, well, let's think specifically about one group at a time. So we're going to think about healthcare workers and home healthcare workers. So if we look at their demographics, and red is home health aides, gray is the general US population, the NIOSH headforms were designed for the general US population. And so what we can see is that there are basically less white people and more Black people on average in home health, right? So then we know that if we're going back to those averages of headforms, this is a particular group that is 10% of the US population that had been designed around to those headforms, but is overrepresented in this occupation. So if we care about the occupation, this is who we need to care about specifically. And again, this is by gender. So by healthcare, by gender and age, we're not talking primarily, young white males. We're talking primarily older, primarily Black women as home health aides. So again, if we are trying to protect this worker cohort, this is our cohort. So again, these are the standards, and I've basically proposed that we need something different. So then the question is, what else can you do? We broke this down into 3 aims. So one is testing 3D printing as just another way of making headforms so that we could get what we want. So that's the method. 2, you have to be able to get our own versions of these models, right? You have to have something to print. And 3, we wanted to test that. So this is the experimental design. We would recruit a bunch of hopefully working home health aides and nurses, 3D scan, digitize their faces, turn that into these purely digital models, and then 3D print them. So then the key tasks, we basically had to recruit people, 3D scan them, process the models, design it to actually be printed, test the printing. So in terms of results, I broke this down into 3 areas. So one was just test the 3D printing. So we can start with those NIOSH digital headforms. We can throw that on a printer and just print it, and it works just fine. So the nice thing is we didn't design this. There was no 3D scanning. This is just out there. We could just print it. So that is actually really very little effort, and I think it costs maybe $10, right? We can go a step further, because if you go to the really nicely engineered headforms, it's not just a chunk of plastic, it's hard plastic and a soft coating. They're trying to mimic skin that has these other functions to it. So we can start to put more effort into it. So this was an attempt. The red is a hard plastic. The black is a soft plastic called TPU. We showed that we could print in TPU directly. But then the question is, does it have exactly the properties of that artificial skin you want? Not really. We could even directly print that sort of functionalized mannequin where the face is the softer plastic and the back of the head is the harder plastic, just like the expensive ones you can buy. The issue there was that now we're running into complexity. We're running into manufacturing issues doing it this way. So still not super thrilled with that method. Third, which is I think the route we would go in the future, is you basically print out this 3D printed mannequin head, but you've removed some material from the face. You make a negative mold, and now you have this area here where you pour in your silicone to get an artificial skin. So then how to do this quickly, cheaply, repeatably is the sort of thing where we need more engineering. So again, that was just for the 3D printing of, even if we had good designs, could we 3D print these mannequins ourselves in a reasonable way? So it's actually looking pretty good. The other question was the data. NIOSH put in years of work, recruited thousands of people to take these measurements to get a very large data set so that they could boil it down to 5 good models. So for us, we wanted to test that approach. So we were at the 1819 Innovation Hub. We scanned 4 volunteers. We had a target of 10, so recruiting was an issue. Each scan only took 5 minutes, and they basically were happy, comfortable. All the volunteers enjoyed it, so that part was actually pretty easy. So the modern 3D scanning, quick and simple. And the takeaways from that was really that it was a good approach of bringing people in, scanning their face, sending them off with like $50 after 15 minutes. I mean, people are generally pretty easy to get to do that. It's just that being in the right places at the right time to get the right recruits was kind of the issue. So that's something that we need to improve. The other thing we ran into are really technical challenges with the specific scanner that we were using. So that's something that we improved for future work. The real limitations actually came in with, one, the 3D scanner. It was a really nice model, cost like $20,000. It was at a central facility, so we had to go to it. That was actually one of the big problems. So it was not portable. It's not something we could bring to the people. And it was not really designed for people. It was eye safe. It was all IRB approved. But this was something designed for parts. So you have a big part, you're going to put it on a turntable and you're going to scan it. So what we wanted was something that's more designed for people, quick, portable, easy. Bring it to the volunteers instead of having them come to us, because that was actually the key barrier. It's just logistics. So that was something that we were able to purchase during the project. Because it was IRB approved, we couldn't just swap this in. So we are testing it, but we're just testing it not directly on people. So we're testing it, I'll show you in a minute, in other ways. The other thing was that the whole concept of recruiting 20 people in nursing so that I could boil it down to a single nursing head form, I think was actually not the way to go. Because I think given how easy and cheap it is to make these, why boil it down, right? Yeah, we're actually getting close. So then what we want is something that looks like this. And again, the artificial skin was something that we really need to put more work into. So for future direction, there's really 2 ways we need to go. One is the engineering of this. I think the motivation is in the right place. We can only do the studies that we have the power to control, right? So if we don't have control over the head forms and the mannequins that we're using, then we're limited to what we have, and the fit that we'll be able to get, the people we'll be able to represent. So taking tighter control over the head forms we use in our studies could be really powerful. So I think that's good. But one, the engineering of it, we need it to be this high quality, right? That's really what we need. The mold over on the left is just not good enough yet. The science, we basically need to try this again with more people and actually get to a problem that matters directly, right? So this on its own is a neat little engineering project, but it's not by itself going to hit the NIH goals. So that's where we're talking about how can we combine this with actual field data to see if we can make a difference. So that's where we need to really talk through what bigger funding on something like this looks like, because it would really just be a piece of something. So this is bonus. Like I said, we were testing the new print scanner in new ways. So this is an acquaintance of mine who's at the University of Dayton in the theater department, actually Professor Clowning. So that is a thing. And what's fun is that, so he's bringing fine art students in. They create their own masks. So over there, you can see a cart full of these little, really funky looking masks. And this is the scanner that we're testing. So because I can't test on people right now, we're testing this to see if this would work in other applications. But this basically the same thing where I had to schedule someone to go over to the Innovation Hub, set up, roll a computer and cart, have a person sit there in a chair, and the whole thing, once they're there, takes 5 minutes, but all the setup and logistics takes like an hour. This, I can just bring these things in, scan them, get a model on the same scanner, export it. So this is working great, and this is just kind of a fun little test that doesn't take much time, but really this is to be preliminary data for, is this scanner going to help us overcome the real logistical challenges of recruiting people? Because this can go out into the field, it doesn't have some of the bright lights that were the only annoying thing on the other scanner for volunteers. And this is the sort of thing that would enable us to go much faster and collect more data on a larger cohort. So really, the point of this was, it started with kind of a dumb question of why don't we have more mannequins, and how do we get there, and kind of testing one engineering approach. And yeah, still a lot of work to be done, right?
Thank you very much. Are there questions? So for the second scanner that you're kind of playing with a mask and testing, what is the cost on that one?
Oh, so that one cost about $1,000.
I'm sorry, this gentleman was first.
Justin, reaching back into your past, have you considered bringing in interdisciplinary senior design projects?
Oh, yeah.
Maybe
Helping recruit them.
ME?
So one of my goals, actually, bigger picture, so Tom here was actually my undergrad capstone advisor in UC engineering. And so I've kind of come full circle, and I'm just seeing the purposes of taking those skills and applying them here. So that's just, it would be nice to get more students over. Yeah.
I was wondering if you're taking into account the different thicknesses of the skin on different areas of the face when you're removing the material?
Yeah, not yet. So that's all digital. Right now, the standard mannequin, we have this nice mannequin, but if anything, I think it's way too stiff. They put a lot of effort into the chemistry of this, but it's the sort of thing that I think we could do, get the same results or even better if we just use a simple cheap silicone that's honestly way too soft for human skin, but then we just tailor the thickness in different areas to get the total, kind of stiffness that you would want. So it's just a materials and engineering challenge, right?
Sorry, I think I might have missed this part of your presentation, but you mentioned that we can't test humans right now. Do you know, why can't we?
Just because one scanner that I wrote into the IRB. So for that study, I stuck with the scanner that I had written it. So I saw the limitations with that particular scanner, how much the exact scanner that you're using matters with the data. And so we bought another cheaper, newer scanner that I think ultimately will be much better for doing this, but I couldn't just drop it in the IRB, right? So that's more about just finding the right way to do it and just kind of not just starting to test people all willy-nilly. I'm an engineer, so I'm still learning these things of like human trials and, if anything, probably being overly cautious.
Thank you. All right, thank you. And it's time for another poster break.